make sure we're recording. All right, so good morning, good afternoon, and good evening, everyone. Thank you for joining us for our March of 2022 Global One Health Initiative webinar, supported by the NIH Fogarty International Center. Our topic for today is monitoring and evaluation for One Health, and we will be hearing from Dr. Saira Nawaz, who is currently a research evaluator at the Center for Health Outcomes and Policy Evaluation, or HOPES, in the Ohio State University College of Public Health, and the lead of all monitoring and evaluation efforts for the Global One Health Initiative. And to briefly introduce Dr. Nawaz, Dr. Saira Nawaz has over 8 years of experience and expertise in public health, evaluation, clinical and health services research in both corporate and government settings. And in her current role at HOPES, she provides methodological support in claims research, evaluation, and cost analysis for center-specific projects. Saira previously worked as a biostatistician at Nationwide Children's Hospital and as an evaluation specialist at the Centers for Disease Control and Prevention in Atlanta. She holds a bachelor's in biochemistry from McMaster's University, an MPH in outcomes research from Columbia University, and a PhD in health services research from Dartmouth College. And she's also paving the way for GOHi's monitoring and evaluation framework, and again, leads monitoring and evaluation for some of GOHi's largest projects, helping to ensure that we deliver on our objectives and achieve sustainable impact. So with that, I will go ahead and hand it over to you, Dr. Nawaz, to share your screen.
Thanks, Laura, and thanks everyone. I think we have a slightly late start, but I think we'll make up the time. I am the only presenter today. Usually we have about 2 panelists, but we were having a little bit of a hard time finding another evaluator who was available, who's kind of specialized in this work. So thanks for everyone for joining and also being a little bit patient for me as I navigate some of the evaluation principles and ideas this morning and this afternoon for our colleagues in Ethiopia. I suspect that we might finish a little bit early unless we have a longer discussion, which I'm also very open to and would be excited to do. So I'll go ahead and share my screen. Thanks, Laura, for the nice introduction. And if you can confirm for me that everything, it looks good.
Yep.
Okay, perfect. Okay, so as I said, again, good morning, good afternoon, everyone, and thanks again for joining. And as I mentioned before, you'll notice that I'm the only speaker for today. So we'll likely have a shortened session unless participants are eager to follow up on any of the concepts that I talk about today related to monitoring and evaluation. And I'll be speaking more broadly about monitoring and evaluation, or M&E, and kind of the principles that I like to apply to my work. And I think a lot of those are evolving. And towards the end, we can begin to look at how we can apply some of these M&E principles to One Health. As everybody knows on the call, probably better than I do, One Health is a very complex system level approach to the work that we do. And evaluation has to match that type of complexity. So we can talk about that a little bit more and what some of those frameworks look like. So for the agenda today, here's a high-level agenda. I'll provide a little bit of my own background and context of this specific work. We'll discuss some of the evaluation principles that may look old, may be evolving, may try to challenge the current approaches to evaluation. We'll speak briefly about evaluation for One Health and what that looks like for GOHi at this time, and then some potential next steps. As Laura mentioned, my name is Saira Nawaz. I am a health services researcher at Ohio State University's Center for Health Outcomes and Policy Evaluation Studies, or what we call the Center for HOPES. At the center, I support health services research, monitoring and evaluation, health economics and cost analysis of public health, behavioral health programs, and then obviously with GOHi, working on some more global health programs. Within the Global One Health Initiative, I support both the M&E of the strategic arm of GOHi as well as the project level M&E. I also spend about 50% of my time with an organization called PATH. I'm not sure if folks are familiar with this group, but they're a global nonprofit based out of Seattle, but actually have several offices worldwide, including in Addis Ababa. And as Laura mentioned, I began most of my evaluation career as an evaluation fellow with the Center for Disease Control and Prevention, developing performance measures and performance standards to assess public health infrastructure strengthening programs for local public health. And I'll just briefly introduce our broader team. These are my colleagues at the Center for Hopes. And they are experts in policy, health economics, evaluation, and health services research, but I will caution that I'm probably the only one who has a global health project at hand right now. Most of my colleagues work in US-based projects. Okay, so context of our work, I wanted to bring it right back to Global One Health Initiative and what monitoring and evaluation means for our particular work. We're looking at both the value add of GOHi in the context of a strategic plan and a mission, as well as to funders in the context of the program. So as a reminder, GOHi has strategic goals, which include research and implementation capacity, education and training capacity, outreach and engagement, and a resource and financial stewardship. And so developing indicators and evaluating GOHi's input in some of these areas is essential, especially being within the academic setting. But on the other side, we are also recipients of major CDC grants. And so we're responsible for establishing M&E tracking systems within the projects and reporting quarterly, semi-annually, and annually on the progress of our projects to push the needle for some of the objectives of our work related to global health security. And lastly, we try to keep in mind that we are also strategic and technical partners for groups on the ground. So the Ethiopian Public Health Institute, the Ministry of Agriculture, subnational representations from each of these groups as government partners, as well as community organizations. So beyond just looking at very high level strategic goals, where typically the recipient of this information is the academic center within which we operate. We also have funders who are looking for support, but we also need to function as strategic and technical partners to support the work and the work planning for other organizations that we work closely with on the ground. And how is monitoring and evaluation relevant to this? At a very high level, we are integral to some of the reporting. As I mentioned, reporting to multiple audiences. Mostly our focus has been reporting to our funders or donors, as well as for in-country partners. We're also engaged on activity management. We want to make sure that programs, projects, strategies are being implemented, and we're able to see at the activity level what's working and what isn't working. And that kind of goes into this piece about program improvement. And that's really where I like to spend a lot of my time working with teams on these last 3 points, which are the program improvement, technical engagement, and evidence generation. I feel that the first two, reporting and activity management, are usually very typical and the day-to-day activity, but the program improvement, technical engagement, and evidence generation require a little bit more thought as to how those can be implemented using the data that we have. So as I previously mentioned, we want to collect accurate data, consume it, and then consider how it can be used to advance program through data-driven decision-making, look at broader context of activities, and provide technical partnership, and generate evidence that can be used by others to optimize their programs, and that's part of the evidence generation, or continue to build on that information to build more evidence and science around our work. And if you're not convinced that evaluation and monitoring and evaluation is important, at least in the US context, there's been a lot more emphasis on evaluation and advocacy around evaluation. This evaluation.com was actually, or .gov, I'm sorry, was released not that long ago, in late summer of last year. But it's the byproduct of a law that was actually passed in January of 2019 called the Evidence Act, which requires that federal governments build evidence and use it for decision making. So these mandates and expectations are coming down. They're actually being implemented and coming down the pipeline, and we need to have capacity to be able to respond to evidence generation and use. This first output from the law, the evaluation.gov, is an effort to build a learning agenda around data and planning for the next phase of activities. And all federal agencies are at the point where they're building evaluation communities, generating combined or collaborated learning agendas. And all of those are going to be informed by evaluation. So there's a lot of momentum right now, at least on the US side and from federal governments at this side. And I think we all have the experience with CDC as well to really be able to use evaluation and make it an active part of our work. So I think the distinction here and my interest on more dynamic evaluation use is coming out clearly. As from the previous slides, I've emphasized the need to have more dynamic systems that inform learning and planning. Traditional M&E tends to be fairly top-down and is usually driven by fairly high-level indicators. And this means that we usually generate a plan and we establish indicators at the beginning of the project, and then we report on those indicators and we report them out annually, and that's supposed to be an assessment of performance. And I think we're tending to move away from that a little bit in the field, where we want to build in more dynamic systems of M&E that focus on collecting and responding to data, and then establishing thought partnership with a broad set of stakeholders. So not limited to funders, not limited to let's say, national partners, but really building out the thought partnership to see how we can address problems and improve and optimize programs. Just to get at this point around static and dynamic, again, this is a logic model from the GOHi activities to strengthen Ethiopia's activities related to the international health regulations. So this is actually a funded activity for GOHi, one of the CDC funded activities for GOHi, where we moved from inputs to activities to short-term outcomes, intermediate outcomes, and long-term outcomes. This is a log framework that we typically develop at the beginning of a program. And we use this model and develop indicators, as I mentioned, around the short-term, intermediate, and long-term outcomes, and report those during a regular time frame. And that's been our approach and process, and that's how we're moving forward with this work. But in the next few slides, I kind of want to challenge some of that static approach and think about evaluation principles that we can draw on to make the information that we're gathering more useful for program improvement, course correction, and evidence generation. So here are the principles, and I'm going to break those down in the few next slides. But I really want to talk about principles for developing more dynamic, multi-tiered, co-developed, human-centered, adaptive, evidence-informed, evaluations and projects that really get to the real challenges or the root causes, and ultimately evaluations that can generate evidence. And while I'm reviewing these, I think it'll be clear that these are not mutually exclusive. There will be some overlap in some of the concepts, but I think it's just a different way, a different perspective on each of these topics. And sometimes it's helpful to think about things in a few different ways, even though ultimately they're probably building to this broader idea of having adaptive systems and adaptive learning. Okay, here we lay out a comparative framework of evaluation methods, but all of them rely on a rapid approach to evaluation, depending on the question and the level of complexity. So usually what happens is we develop these summative evaluations. We've got this, here I can go back a few slides. We've got this broad logic model. We tend to focus on, okay, how are we performing on the short-term outcome? How are we performing on the intermediate outcome? And then we develop a report on performance, and that's considered to be summative. And usually getting to those intermediate outcomes requires 2 years of implementation plus another year of evaluation. So by the time you get that information, it's about 3 years. And so this is sort of challenging that structure where we say that we don't want to look at the summative or the end term evaluation over the full duration of the program. But here we're actually thinking of not necessarily, if people are familiar with this idea of process evaluation, which is looking at the performance on various process measures, but it's actually thinking about short-term summative evaluations, that's short-term reflection on the outcomes of a project, but having that done in this very rapid period. So the level at which we are looking at the intervention will kind of dictate the type of rapid evaluation that you'll look at. So if it's a simple process improvement project, we might use quality improvement methods. If it's a complicated organizational change, so it requires some changes at a much higher level and investments at a higher level as well, we would look at a rapid cycle evaluation or rapid evaluation. And if it's a systems-based change, or sorry, if it's a large scale or systemic change, we might look at systems-based rapid feedback methods so that we're continuously getting information about how these large scale changes need to be implemented. We also want evaluations to be multi-tiered. The figure that I have included here is the socio-ecological model. And it's not, it's used as a framing around designing healthcare and health services and health delivery models. But the point that I wanted to emphasize with this particular model is that we know that systems include multiple people, and evaluations need to parallel that. So this means that evaluations should be multi-tiered and likely include multiple perspectives. Again, if we reflect back on the logic model that I shared with you before for GOHi's activities, it definitely includes the perspective of people who are designing and implementing, so the technical leads on these projects, as well as CDC's perspective as to how they think their investments are going to lead to long-term outcomes. So I guess the principle or my recommendation here is really that in addition to early stakeholder activities that happen to design and validate the evaluation approach, we also need to consider metrics, strategies, evaluation practices where we can include perspectives not only of technical experts, and in this case CDC, but really perspectives of community members, civil society, providers, veterinarians, public health officials, zoonotic scientists, et cetera, whoever else is going to be part of the program implementation or impacted by the program, it would be helpful to include their perspectives in the evaluation because they're going to really be the change agents for implementing the program. This idea of co-development, and as I mentioned before, these concepts are not mutually exclusive. So you'll see some of them are building on each other, or we'll talk about principles from a different angle. But the co-development really involves working closely with community partners to co-develop interventions. So most of my work relies on effective community engagement with partners that are considered experts within their own context, and thus the type of programming that may be needed within their community and to address community challenges. Although we initially forge a partnership to co-develop an evaluation approach, what I've noticed is that there needs to be a lot of capacity building around implementation and process improvement to really strengthen programs. So you can think about co-developing interventions with community members. You can also think about co-developing evaluations with community members. But the one thing that happens occasionally is that we want to co-develop evaluations, but we also need to understand if there are gaps in capacity to be able to collect some information, use the information for decision making. And that's where someone like us on the GOHi side who are supporting M&E can really fulfill that capacity. What we try to do is also think about how this information can be used for adaptive learning and course correction. But the real emphasis here is co-development requires an equal partnership and building of trust. And so our evaluation methods that may be employing co-development really need to, it requires some deep listening from our partners who are co-developing the methods so that we can be equal partners in developing the strategies for evaluation and continue to help the teams use the information for program improvement. Okay. If evaluations of projects are co-developed, they tend to be human-centered. And what that means is that we are really looking for inputs from the users to optimize project implementation, but also to optimize the evaluation activities. So in my work at PATH, we've used human-centered design approaches to really advance goals related to more routine care, such as family planning and vaccination. So if we're noticing that some individuals just will not come in to get their vaccination, or they don't feel comfortable coming into a clinic for family planning, we really want to understand why from the user's perspective. So this approach is to identify a user group and who can ideate on solutions, help design them, prototype them, test them, and then evaluate them, and then confirm that we have a positive user experience based on these changes. So I see a role for evaluators in two places when we think about human-centered design. One is that we can be engaged on this part, which is evaluation of user types and advancing solutions to overcome implementation challenges. The second part is that we actually, within evaluation, use principles of human-centered design to maximize data collection that requires individuals on the ground to provide us with high quality data, which is sometimes a challenge. So thinking about how can we design systems of data collection and evaluation, which will allow us to get information that's useful, that's reflective of the situation on the ground, but that's also of high quality so that we can use it for data-driven decision-making. So as an example, we know that DHIS2 is a primary data collection tool used in countries to collect public health information. And we can, as evaluators, can often rely on this data source for secondary data. If we are reviewing the data, the DHIS2 data, and we note some significant gaps, it may be useful to quickly develop a user group to understand what would be helpful. For example, would it be helpful to have reminders for teams? Would it be helpful to have checklists? would it be helpful to have like a very short quality assurance tool that we can provide to those who are entering the information? And then we would prototype those, we would test those, and then if they're helpful, we would try to institutionalize them to make sure that the data that's entered and that can be used for evaluation is of high quality. So that's just one example of how we can make things human-centered by relying on the user to guide us as to what solutions we can implement. Okay, as I mentioned, there's several principles, there's some overlap, but ultimately everything kind of builds into this idea of adaptive learning and management. So despite our best intentions, projects don't always progress the way that we hope. And oftentimes we know why, especially if you're a technical expert in this space or you've had a lot of experience with the program. Usually you know why things may not be working. You may know how to improve them or how to optimize them, but it's always useful to collect the correct information to figure out the best approach for how to make improvements or adjustments to the plan. So an ethos of adaptation and flexibility can be very helpful as we try to understand how to improve the work. It's considered or defined as an intentional approach to make decisions and adjustment as new information is gathered or if there are changes in the context. So using data either regularly collected or data that can be collected at one time, we begin to closely track if there are challenges, why, and whether small adjustments or changes can help overcome those. So the learning part of this approach is essentially as it requires people to be willing to actively refine their beliefs or assumptions around what they think works and why. And that's really the foundation for how adaptive learning and management works. We often have preconceived ideas as to why things are going to work and that they need to work and what the gaps are. But having an open mindset and an adaptive mindset around, well, let's really try to use the data to inform us as to whether some of the assumptions that we have, some of the beliefs that we have are truly playing out the way that we think is a core part of adaptive learning. And what I'll say is that most people on the ground, especially in the work that we do, they have this mindset. They're very adaptive, they're very flexible. And I think we are intuitively always doing this, but we can build strong evaluation systems to begin to do this at the outset. So instead of, again, looking at those long-term outcomes, we bring evaluation along with us with program implementation, testing assumptions, thinking through challenges so that we can more systematize this approach to adaptive learning. So the next three principles that I'll reflect on rely on engagement of evaluators as part of the intervention design and planning process. Typically, when I'm engaged on projects, they may have already been implemented or are well on their way for implementation. And so the next three principles really talk about how it's always better to engage evaluators much early on as part of the design, as part of the development of the theory of change, because then they're able to develop systems around the ideas or the backbone of the project. So early engagement through partnership can be essential and can be very helpful in maximizing the usefulness of the evaluation support and data. So understanding how evidence has come together is useful for evaluators as it helps understand what needs to be monitored in case things don't work well. For me, this has really meant pushing my colleagues to develop and share theories of change. And sometimes theories of change, ideally theories of change are happening at the beginning of a project, but there are times when, we get funding, we need to think about implementation and we need to move forward. And the theory of change can oftentimes come a little bit later. But what the theory of change allows us to do is it allows us to really reflect on the evidence-informed or the theory-based linkages that exist between intervention activities, but also think about the broader context that within which we are implementing the program. So here you can see a theory of change for increasing vaccination demand and vaccine availability. It is not ideally as complex as we would want it to look like. It's definitely incomplete, this particular theory of change. But the one thing I wanted to focus on was that we added in this column here, this box here about level of involvement. So everything to the right of that, the community-oriented approach, the provider-oriented approach, and all of these activities represent actual implementation, but they're all driven by this broader context as to how deeply providers and community members are engaged on the activities. So this represents a spectrum of engagement, and that context is very important to understand, well, how well are these activities going to be implemented? And if we see that, for example, partnerships with county level vaccine clinics are not being implemented to the extent that we would like, we can come back to some of these contextual principles. How engaged are providers on this particular initiative? Do they prefer to just be informed, or do they truly feel like they can collaborate? Because that's going to really dictate the strength of the partnerships, for example. So having some of these external elements outside of the activities can be very helpful. And those usually come through as we do activities related to, or exercises related to theory of change. Okay. Again, this is going back to, the thinking about the inception of the work. So obviously, as I mentioned, evaluation tends to come in a little bit later once the programs are designed, but it can be very helpful to have engagement very early on as people are thinking through what type of programs, what type of projects do we want to implement to address a particular problem. And one of the reasons for that is because we really want to push to get to root causes. We really want to push to think about what are the root issues that continue to happen that make it challenging for us to achieve successes in the program. So an added benefit of getting deeper into the why and how using theory of change is that you can really get down to what we refer to as the root cause of the work. In this particular, this is not a theory of change, but it's the step right before a theory of change, which is really looking at what are all the challenges that exist and contribute to this main problem of low and undiversified income, especially for women. Getting to the root cause requires looking at this first level and then saying, well, what contributes to that? And then looking at the second level and then saying, what contributes to that? And going further down to see, well, what is the root cause that really continues to make some of these other problems challenging to address. And so if those so ideally what we want to do is we want to design interventions, projects that get to this root causes. However, if these seem insurmountable, we might take a layer up. And so we might address something that's not necessarily the root cause that we've discovered, but that seems to be more attainable in terms of project development or project design. And so what it's good for us to keep in mind, especially as evaluators, is that this root cause will continue to present a challenge. It will continue to be this entrenched obstacle that we hope can be overcome by our interventions, but it's always good to keep in mind that these are things that we want to monitor and track. The other piece that I'll say is that we learn more and more about the root causes as we go through the process of project implementation, as there's new evidence that's being generated, as other people are implementing projects. So we continuously need to adapt and iterate our approach so that it's updated, that we understand what the root causes are. Perhaps this root cause, there will be evidence that there's an even deeper cause. So just continuing to keep these theories of change our logic models, our contextual framing updated and iterated as we learn through our own program implementation or other evidence that's being generated. Okay, and then that leads me to this last part about evidence generation. And I don't think this will be the only space where this talk has been editorialized, but this one piece that I'll say is that I feel that we often operate in some extremes. We operate as completely evaluation, completely research with maybe little discussion of what the overlap is. And I tend to operate a little bit in this gray space where I understand the limitations of having a non-experimental model, or maybe even relying on a quasi-experimental model. But I still think that a lot of that information, the evaluation information, is not just important for internal stakeholders or funders or other stakeholders, but really thinking about how can we publish on that for practice-informed science. So on the other side, I do feel like in the space of monitoring and evaluation, we do not push ourselves enough to really think about rigorous designs and techniques that we could use to make the case that something is working or it's not working compared to status quo or care as usual. So what I've included here is some more rigorous approaches or quasi-experimental designs. Some of them have deliberate control groups like differences and differences, but some of them have control groups that are generated or informed by the data. So interrupted time series, regression discontinuity, instrumental variables, and propensity score matching. The one disadvantage of some of these approaches is that you need a lot of data occasionally to make them useful and helpful. And things like instrumental variables, when I've had the experience where people have used them where they're not appropriately used. So I think having a greater capacity to understand when and where can we use some of these quasi-experimental models to add deeper rigor into evaluation is also very important. And the other thing I'll say too is that a lot of funders, especially the Global Fund and GOHi, are really looking towards using strategies like interrupted time series and other approaches as part of program design, but also as part of evaluation. So I think even funders are moving into this direction of more robust evaluation. Okay, so moving along on our agenda, and keeping all of these principles in mind, and I'll just say I only have a few more slides actually related to One Health and some of what we're applying. So I'm hoping we're going to move to some discussion soon. But keeping these principles in mind, I wanted to shift to topics that are probably more familiar with folks who are on the phone compared to me. So how using these principles, but also thinking about what is the complexity that is One Health, how best could we evaluate One Health? And this is probably just a reminder to folks, but One Health refers to an approach of tackling what we call wicked problems of zoonotic infectious diseases, environmental pollutants, antimicrobial resistance, climate or market-driven food system changes, malnutrition, and many other problems, by recognizing that the spheres of humans, animals, and ecosystems constituting their environments are all intertwined. And as a result of that, it requires an integrated and transdisciplinary approach with multi-sectoral engagement. And here, what I wanted to do was just to break down how we're doing evaluation related to One Health in a programmatic sense or a pillar level sense, and then what is being proposed as more initiative level One Health frameworks for evaluation that I myself have not implemented, but I think would be good to discuss on the call. So within our own team, we've been looking at evaluating some of the program level investments. And what I mean by that is that as part of our work, we are looking at certain pillars for building capacity and really trying to understand what those investments are and how they're leading to outcomes. And one exercise that we've been doing is called causal linkage monitoring. And causal linkage monitoring, it allows us to get down to what the assumptions are for our activities. So if we go back to the logic model that I had shown everyone, we've got our activities, outputs, outcomes, and impact usually well laid out before we start implementation. But the one piece that we're often missing is, well, what are the assumptions? What do we think needs to happen so that we can move from the activities we're implementing to the outputs? And then what do people have to do with these outputs so that they get to the point of the outcomes? And so really being able to build out, well, what are the assumptions? What are the linkages that need to happen has been some of the work that we've done internally with the team. And I just wanted to share an example. I want to say it was maybe 2 weeks ago or a week and a half ago. We conducted an M&E training with M&E experts from the Ethiopian Public Health Institute, as well as the Ministry of Health and the subnational representations from those groups. And we conducted this exercise where we really tried to walk people through the causal linkage monitoring exercise, looking at the COVID response in Ethiopia. And you'll see these are large buckets of activities, but we tried to emphasize this piece about the assumption. So we worked from awareness creation. I'll just take an example here of an activity related to awareness creation on prevention. The idea was that it gets us to the output of increasing the number of people who are attending awareness sessions, and then the outcome of, well, then we're just going to have improved knowledge and attitudes and practices, right? But there's a lot of assumptions that we're applying to this model. For example, we want to make sure that we have sufficient media engagement and interest at a very high level to get some of these messages out. We want to make sure that we have sufficient number of community health workers who can support outreach and who are trained to do that level of outreach. We want to make sure that community leaders are engaged on this. We also need to make sure that there's sufficient demand within the community to participate in some of these awareness activities. So that is a huge assumption that we're making between the activity and the output. And then I think another assumption here, going from increased number of awareness creation sessions to the outcome, again, is that we have sufficient community member participation from all areas, because we want the awareness generation and the participation in this awareness activities to be equitable, so as to truly reduce transmission, and that once they participate in these activities, many of their concerns related to COVID will be addressed, or many of their questions related to COVID are going to be addressed in these type of sessions. So that's an assumption moving from participation in the awareness creation activities to improvement in knowledge and ultimately reduction in transmission. So I'm hoping that kind of spotlighting that particular example is helpful to show you why some of these evaluation activities can be kind of useful, because we want to push people to think about, well, if the media buy-in isn't there, or the media engagement isn't there, the messaging isn't there, it's hard to move from the activity to output. And so how does evaluation become engaged on this? I think one, we push people to think about the assumptions. And then I think the second thing that we do is we say, well, are any of the assumptions really so significant that we need to continue to monitor them to make sure that the programs can be implemented in a way that gets us from the activities to outputs? For example, if a lot of our strategy, the assumption is dependent on community health workers being available for outreach, we may want to continue to monitor, well, how many community health workers are there? How many of them have been trained on COVID? How many of them are actually present in different communities to ensure equitable spread of the information? So Evaluation can be engaged on kind of maintaining or monitoring some of these assumptions. And then if the assumptions fall through, at least we know where we need to pivot. Okay, another activity that we need to get to work on is doing a little bit more of the root cause analysis, which I think gets to something that I mentioned before about the theory of change, where we try to get deeper and deeper into the theory of change. So for GOHi's surveillance activities, there's been a lot of successes with the surveillance activities and representation at all levels, at subnational levels as well. And there's been a lot of success related to capacity building. But there's always going to be challenges. And a lot of the challenges, I think, can be very familiar. There's limited training and capacity, there's stockouts, there's challenges with data systems, there's challenges with health worker motivation, and there's always challenges with correct budgeting and financing. I feel like that one comes up a lot. But I think what we want to do is really look into each of these challenges, what look very familiar, and try to break them down more, and try to see what the root causes are. Is the root cause that there might be lower capacity on financial management, for example? So the funding is there, but how to allocate the funding is challenging. Is it that the health workers, there's a challenge? Maybe one of the root causes could be that people are very motivated. The problem is that they have concerns about the longevity of a particular position, for example. So they don't feel as motivated to participate in this because a lot of the funding can be temporary, or they don't receive their money in time. And maybe the root cause for that is that there are no natural systems built in to ensure that healthcare workers receive funding on time, or whatever it is. But it could be that we don't want to just limit ourselves to saying health worker motivation is an issue, but really we want to understand, well, how do we address that? What is the real root cause to that? And what can we solution around that? So as a next activity, and I know Lul's on the call here, so I'm gonna, I think I want to engage on this a little bit further, but how do we move from familiar challenges, which tend to be the problem at the surface, and get down to, well, how do we begin to address those by really understanding what is the root cause? And oftentimes we can do that by asking these 5 whys, right? So we have limited training and capacity. Why do we have that? Well, we have limited funding for that. Why do we have that? Well, people struggle with allocation. It's not predictive when we want to do limited, when we want to engage on training. Okay, so the solution can be that we want to make sure that we have repeated trainings or capacity building sessions, which are very predictable, and where we want to ensure that funding can be allocated, for example. And so breaking that down a little bit deeper is some of the work that we may be doing related to the surveillance support. Okay. So the next few slides, truthfully, are a little bit newer for me, a little bit unfamiliar, but I thought it would be important to include them here because I think it presents a lot of opportunity for collaboration and deeper systems thinking around the concept of One Health. So this is a framework that has been put forward by a team. I think they're based out of the UK, and it's a framework for evaluating One Health. And it requires systems-based thinking. And so systems-based thinking is really not looking at the split, which is what I've shown you before, like the logic modeling, the various strategies within the logic model, doing a deep dive into surveillance. That's really splitting, and then really not thinking about the broader context and the broader environment. That's looking at things as a split, but really looking at evaluation of One Health as a whole requires more complex approaches and a systems approach, and really thinking about, well, how are components linked by interactions? How is one activity linked to another? Then how is one factor or contextual factor kind of mediating that relationship, and thinking about all of that complexity in one approach. And what this group in the UK has done is that they've developed this framework, and they're really doing a lot of test cases or running case studies to see, well, how well is this framework characterizing the One Health activities? What they've done is they've broken the framework into 4 elements. There's the broader system or the broader context, and what that looks like in terms of interactions, what are the various components to that. And then they put the One Health initiative as a subsystem within this broader system, and really thinking about, well, how does this subsystem then lead to changes in outcomes of the broader system? And I'll show you that in a second. The third element is assessment of the initiative in terms of One Healthness. And again, I'll illustrate to you what that actually means, but this is essentially a process evaluation of the One Health initiative, but the dimensions of this are quite interesting, actually. And then the last piece, which is element 4, is really trying to make an assessment of, well, with this One Health initiative in mind, how well are we achieving outcomes, and how does that compare to other types of initiatives? So this is a framework here. And again, I'll walk through it, but you'll see that element 1 is really the definition of the system. And the definition of the system, I think we want to see it in all its complexity. How are things interrelated? What's the influence of one factor on another? What's the feedback loops that are set into place? That's kind of the very holistic system that we want to reflect on. And then within element 1, we also want to be very clear, based on our theory of change, well, what is the One Health initiative as a subsystem within the system? And what do shifts look like if we were to, and that kind of feeds into element 3, if we were to implement this One Health initiative and we have a theory of change, what do we know is going to be influenced within the broader system or the broader context through the One Health subsystem? And that's where we follow the theory of change. We think about what the final outcomes are, and then we think about, well, what is the design of the evaluation and the metric to really get us from the One Health initiative all the way down to the final outcome. So this would look similar to a summative or end of project evaluation. Element 3, I thought, was kind of interesting because this is really an assessment of the One Healthness. They actually have an index that you can look at, but in general, you can look at some of these dimensions and make an assessment as to how One Healthy or One Healthness this particular initiative is. Does it implement ideas of system thinking? Does it implement integrated and cross-sectoral planning? Is it considered transdisciplinary? Is there a process of sharing infrastructure and processes between sectors? Is there a learning infrastructure that's in place? Is there shared leadership, and is it adaptive? And so a lot of the things that we've been talking about as principles for evaluation are also tied in very closely with principles of, well, how One Health nature is a particular initiative, and how can we evaluate that? So this is sort of the monitoring piece of the work too, but using these various dimensions. And then this would be, element 2 would kind of lead to the more summative, like overall, what has that One Health initiative done in order to shift the system and achieve various outcomes? And then element 4 here is really just a comparison. How cost effective is it? What is the value add of such a One Health initiative as part of the broader system? Okay. Yes, I'm looking towards concluding the call so that we can have maybe a discussion. But just to highlight on our end, the next steps for the monitoring and evaluation. is to continue to monitor and evaluate the CDC grants based on those pillars that I had shown you in the very early logic model. Also thinking about tracking and monitoring of the GOHi strategy, which is a little bit more high level, and the audience tends to be a little bit different. But also I think one of the next steps, just reflecting on where One Health evaluation is and how we want to integrate that more, I think within GOHi, is really to think about broader collaborations with One Health researchers to see how we can implement this kind of framework or aspects of this framework into our work. So I think that's my last slide, Laura. Let me just make sure. Oh, yep. And I just have my contact information here. But I will stop there and see if there are any questions, and I will try my best to answer them, but I also see a lot of my colleagues on the call, so I may be able to defer to them as well. Thank you.
Thank you so much, Saira, for that wonderful presentation. That's very helpful to get a good overview of monitoring evaluation, what it is, why it's important, and branching it into One Health. Which I know it is coming up with these frameworks for One Health is sort of new. And so seeing this is extremely helpful. So thank you so much. So yeah, we will open up to questions. If you could enter your questions in the Q&A, that would be wonderful. And we'll go ahead and start with the discussion. I can always start with a question.
Yeah.
Yeah, so so like you mentioned, most of the monitoring evaluation is this sort of human-centered approach. And so now that we have these new frameworks that are moving towards the One Health. So what you presented is one very valuable way, but sort of how do you, so like when we don't have structures necessarily, frameworks or animal monitoring or monitoring in environmental systems, do we have to come up with a structure within those areas first in order to combine them? Or what are your thoughts on that? I don't know if that makes much sense, but.
Yeah, no, it's a good question. Cause like what are the foundations, or what needs to be in place? What systems need to be in place in order to actualize this, right? And that's what I was kind of overwhelmed with too when I looked at this particular framework, because as we know that sometimes those collaborations can be, they can wane sometimes, right? So if there's a lot of investment around One Health, people are working together, there's shared leadership, there's intentions to kind of organizationally combine, there's intentions to cross-sectorally combine, but then if that wanes, then we don't have that base system to continue to evaluate this work. So I don't know if I have a good answer around that, because ideally, like if I was like a third-party evaluator, like an external person, I would say like, okay, I wouldn't touch this unless all the systems are in place, but we know that that's just not feasible. So we have to come in at different stages. And I think what we say is like, okay, we have shared leadership. We know that people are collaborating and talking, but maybe the systems aren't in place. So let's kind of think about more of a phased evaluation where we start to look at, well, what's the leadership strength? And then move from there. So I think to answer your question, like not everything is going to be 100%, but there are still ways for us to phase in, what we want to look at and how we want to evaluate it. And then it could be the situation where like the shared leadership is actually the most important thing and the systems are very secondary, right? So then we really don't want to lose the momentum on that, and we want to continue to monitor that.
Thank you. Yeah, that's a wonderful answer. Very helpful. All right, so we have some questions. I'll go ahead and read them off, starting with first question. When funders are traditionally concerned about outputs, how to make sure our work is leading to outcomes?
Yeah, good question, Amanda. I think it's always a negotiation, right? And it's always internally a negotiation, because I think you could make the argument that, internally maybe teams are more interested in what the funder is concerned about. And so the funding for evaluation and assessment may stop at the output level. Like, okay, we've done the deliverable, we've done our work, we feel comfortable with what we're doing. The outcomes, we don't necessarily become engaged on the outcomes. This has to be a broader effort. And I think being able to negotiate that we need to push ourselves a little bit further to make sure that we have impact is important. I think building strong stakeholder relationships, I think being able to look at more non-traditional sources of information. I think for me, I find that scheduling site visits and doing things on the ground to reaffirm that your output is leading to the change, the behavior change, or the system level change that you were intending, even very early on in the process, can be helpful. So if you're doing training and your output at the end of the training is, okay, we've achieved knowledge change, or we've achieved some level of competency, the next level for me would be like, okay, let's go see in the place of practice whether this is actually leading to changes in practice and changes in institutionalization, for example, of practices that we know would be beneficial to the system. And those are kind of the trickle down from what we're doing, but we want to confirm that they're actually leading to change on the ground. I don't know if that answered your question, Amanda.
All right. Well, I think we'll move on to the next question.
Yeah.
So do you have direct experience, or it sounds like maybe an example of when monitoring evaluation results were used to change a program?
Yeah. I have a lot of examples from that. Some of them, the ones that are more time, like I think if you're looking at a 5-year evaluation, sometimes not as much, but I think what I tend to focus on are some of the short terms. So rapid evaluation of contact tracing programs have led to improvements of those programs. Right now, our team is doing in the DRC, they're doing a rapid evaluation of a mobile vaccination strategy. So doing more outreach and mobile support, really supporting the government on doing mobile vaccine, or setting up mobile clinics for vaccination. And what we're doing is having daily data collection, daily debriefs, and then towards the end of the phase, really doing what we call a pause and reflect, which means that we collect the information, we look at it with a series of stakeholders, and then we try to identify, well, what are we learning from the information? What can be improved? And how do we sort of do that quickly? So I think there's a lot of spaces where you can definitely use monitoring data and evaluation data. And some of it, for me, has led to, well, we're going to stop a practice, we're going to amend a practice, we're going to change the approach to a practice based on the data that's collected. But in my experience, what's been most useful is kind of either doing phased data collection or doing rapid data collection and making sure you have people's attention on the information, even if it's for a short period of time. I see a question about the 5 whys. And let me go. So I can go back to, there's this, and I tried to reflect it a little bit before as well. How do you set it? Okay, so typically if you see a challenge, a broad challenge. So for example, if we were to say, one of the challenges that I deal with a lot on projects is this idea of like, you know, the data quality is poor data quality. And you kind of lay that out as your primary challenge. The 5 whys get at, well, why is the data quality poor? And you continue to ask the question, well, okay, well, the data quality, what do we think is the main reason that the data quality is poor? There is a lack of maintenance of the data quality. There may be few people who are trained in data management. There may not be sufficient institutional support for review of the data. And then after that, you then ask, well, why aren't people trained in data management? And then you kind of identify, well, that's not a priority. There's not enough funding for it. There's not enough training opportunities within country to do it. And then you say, well, why aren't there enough training opportunities? Well, because when funders come in, they have a very specific amount of time where they invest it, but there's nothing kind of systematic to train people in data. And so it's kind of an example of, well, if you were to ask why, you could probably get at some of the root issues as to why these challenges continuously appear. So data quality is not just an issue for surveillance, it's an issue for vaccine data, it's an issue for financial decision-making, it's an issue for other things. And so what is the root issue comes from this practice of just trying to delineate, get further and further as to, well, what is the cause and what is the cause specific for our area of expertise?
Thank you.
Okay, I'm trying to run down the list here. Okay.
Do you want me to go ahead and read, or?
Yeah, I'm at this question from Design. Design, you already know the answer to this. How can we differentiate evaluation from research? Both are systematic assessment. What is the difference? So I think in a very IRB type sense, so evaluation usually emerges from a project already being designed and with plans for implementation. So it's usually reflective of like a necessary activity that has to go along with project implementation to make sure that things are moving well. Research is usually hypothesis driven and typically has to include experimental design that helps us figure out if something is working or not and allows us to test the hypothesis. So that's really how I differentiate it. Research is usually coming from a long line of questions, a long line of evidence that will then inform the next step of the research that you're trying to do. Whereas evaluation, I think, is very much paired with, well, we have a strategic goal or we have a programmatic goal and we're beginning implementation and we want evaluation to be paired with that. However, the one thing that I say is that I think the evaluation framework and the evaluation approach, not necessarily that it has to be translated into research, but the difference is that evaluation would be useful if we disseminated the findings a little bit more. So I don't want it to transition to research, but I do think it gives us information about on the ground realities that need to be disseminated as part of the scientific literature.
Great. The next question is the impact of awareness creation links to behavior change. How do you evaluate the impact of awareness of the target community?
Yeah, that's a good question. I would say I'm not sure. This was an example that came from discussions with the team. Like I don't know that I'm the right person to answer that question. How would you evaluate the impact of awareness of the targeted community? So let's go back to the logic model. What we said in terms of impact or end-term outcome was improve knowledge, attitudes, and practices, which I think our team is somewhat engaged on doing some of this, doing this type of surveillance. So I think if you wanted to look at impact of this work, and if it's for a particular community, you might do, you could think about developing surveillance or regular monitoring of changes in knowledge, attitudes, and practice changes that might be coming from the implementation of this work. That's one way to do it. If you're looking at it in a targeted community, again, you could do something where you go on the ground, you identify households, you kind of do a random sampling or oversampling of a particular group of people, and then administer these kind of surveys. That's what I would think, but I'm not an expert. I think for the second question too, how can enhancing lab capacity for zoonotic diseases using the One Health approach? That's a bit out of scope for me. So I can push that back to somebody. Let me just look at this last question and then maybe I can push that back to somebody else. Is there any global One Health evaluation and advocacy approach framework? I wonder if there is a way to address the broad, that's a really good question, Biniam. What I can do is I can share the evaluation piece, but I would say if you look through the evaluation framework that I shared, a lot of that, and I think this speaks to Laura's question at the beginning, a lot of that relies on strong advocacy and systems that are being set up for One Health. And so there's a lot of assumptions that are made within that evaluation framework, that people are already working together, that systems are already combined, that there's already shared leadership. And so I think using that framework to say, listen, these are the basic tenets or the basic principles that need to be in place for One Health to be successful, I think is like kind of a nice way to look at that framework. So I'm happy to share that paper, that article more broadly with the group, but I do think it's kind of a nice basis for advocacy because they're saying these are the basic principles that need to be in place for One Health to be successful. Thank you, Lil, for answering that question.
All right, so just to announce to everyone, or so everyone's aware, so I think this is regarding the community-based, or the assessing the community, the question about assessing the community. So Lul, thank you for responding. You're saying we can do it either as a KAP survey using questionnaires or observational studies to track community practices based on the knowledge change. So thank you, Lul, for answering that and following up. It looks like then the question about the lab, I'm trying to think.
Laura, I mean, I
Yes.
just question, and the question itself isn't clear. And Khalid, if you don't mind, thanks for your contribution again. If you don't mind clarifying the question, because it's not as easy, it's not like a clear question. How can enhancing laboratory capacity for zoonotic disease using One Health approach? How can what? If you clarify that one, we may come up with something. Otherwise, Saira, it was indeed such an amazing and insightful presentation. And want to throw one quick question from my side in terms of measuring outcome and output in the presence of different actors. When you want to measure your own outcome, while there are, yes, we may have different strategy, but if you don't mind bringing in your experience in there, if there are any, strategy to measure,
So being able to carve out your own contribution, is that what you mean?
Yes, there might be, different actors working on the same, similar kind of activity, contributing to, and then you want to make, so yes, collective evaluation can be done, but you want to report to your funder how much outcome
you're contributing.
So if you may reflect on that piece, that would be great. Thank you.
Sure. Yeah,
Okay.
I think that's where you can think about how many intermediate things do you want to measure, right? Because sometimes we go from, okay, we've done this activity, we've hit the deliverable, and then we go all the way out to here's the impact, here's the outcome of our work. But you may want to think about adding in a few intermediate pieces, intermediate measures, because I think being able to carve out like, well, okay, we contribute 25% to this broader goal. Frankly, it's just not going to happen, because you're not going to be able to say we contribute 25% to reductions in mortality unless you have a strong evidence to suggest that, right? So I think my solution around that is really just to continue to build a few additional intermediate outcomes to say, okay, let's say we did, we organized a One Health meeting, you know, we've been advancing that, those work groups. Well, then what did those work groups accomplish? What are the action plans that got implemented? And now we know that the action plans are leading to X, Y, and Z in terms of increasing, you know, rabies vaccination rates or whatever it is. But to say, for example, our role has been, maybe rabies vaccination may be a little bit different, but to say that GOHi on our own has contributed to X percentage of the broader mortality measure, I think will be very, very challenging unless we have this kind of repeated evidence base that gets generated. But I do think you can build out a little bit more what our contribution is. We don't have to stop at the output. We can push that a little bit more, so we can make a stronger case as to what our contribution is.
Thank you. And does that answer the question?
Indeed. Yeah, I like that idea very much. Yeah, thank you again.
Wonderful. And so I don't see an update on Khalid's question. So let's see, last chance for any final thoughts, and then if not, great. Well, thank you so much, Saira. This has been wonderful, wonderful presentation, discussion. Thank you for your time. And then just a reminder that our next webinar for next month will be on April 21st, and we will be hearing from Dr. Alistair King with Merck Animal Health. And he will be presenting on surveillance, where we now, the barriers of implementation and how we may overcome them. So thank you so much again. Oh, and looks like, yep, we got some, thank you, Saira, and thank you to everyone for joining, for your wonderful questions. We look forward to seeing you in April. Thank you.
Thanks, Laura. Thanks, everyone.
Bye, everyone.